So welcome everyone to our ASPO webinar on pediatric thyroid disease and nodules and all the exciting updates that we have to present and talk about today. We have four speakers. I'll introduce them each before they speak. We'll save some time at the end for questions from the audience, so please include them in the chat. But at the end, we'll be able to go over those and some additional interesting cases if there's time for that. Our first speaker is Dr. Hilary Seeley, a pediatric endocrinologist and co-director of the Thyroid Center at Stanford Medicine Children's Health. And she's going to start off our webinar. Let me make sure I'm not sharing screen.
That's great. Let me get to presenter view. Now does it look correct?
Not yet.
Oh no, man, it's just every time. All right, how's that looking, folks? Nothing like starting a presentation with the screen flipped. I'm Hilary Seeley. I'm one of the peds endocrinologists at Stanford. Really nice to be with you all this evening. So I'll just kind of introduce our topics. I wanted to go over kind of triaging thyroid nodules, how they might come into come to your attention through referral. Go into just the basics of initial evaluation. I think you all know a lot about that. And then kind of think a little bit more about how to organize a pediatric thyroid program at your institution. So first, is it really a thyroid nodule, right? I think we get a lot of referrals and don't always know until you kind of see the images and have the exam. But just kind of thinking about, we had established kind of a workflow with our oncology and surgical teams to kind of say, hey, is there really, can we identify some factors that would flag some people that, where they may not be seeing the right person? So certainly if they are age under 8 years old, obviously, so medullary thyroid cancer could present much younger, but say generally speaking for differentiated thyroid cancers, 8 years and older is a ballpark of what we're expecting. If they have B symptoms present, that would be a flag. If they have an abnormal TSH, maybe it's a hyperfunctioning thyroid nodule. Or if the mass does not clearly arise from or involve the thyroid, which I think is hard because you'll get an outside read from someone else and you may not have the images themselves. So if you do have any of those features, I would say the differential includes non-malignancy. So branchial cleft cyst, infection, maybe some ectopic thymus tissue that, is a little bit north of where it typically is, just some other congenital anomaly or a hyperfunctioning thyroid nodule. Malignancies that could present in the neck like this would be lymphoma, maybe rhabdomyosarcoma, soft tissue sarcoma, or neuroblastoma. And, having friends nearby who you might involve if that's appropriate. So initial evaluation, neck ultrasound. So some of you may do your own neck ultrasounds, but certainly reviewing the images and kind of getting those ultrasounds from a group who kind of images the neck often with protocols, I think is important. Laboratory studies that they may come in with, or you would think about getting, certainly a TSH, plus or minus a free T4. We would typically get a thyroglobulin level and a thyroglobulin antibody level. Often a TPO antibody, I think, can be helpful if you're counseling people down the road about a lobectomy. That can kind of increase or decrease the child's risk of developing hypothyroidism. Vitamin D we'll often get just to understand if we need to give them vitamin D preoperatively. And sometimes we get a calcitonin if the imaging or kind of the demographics of the patient indicate that maybe they have a higher risk of something like a medullary thyroid cancer. And so, going for diagnostics in terms of the fine needle aspiration, you all may have different protocols at your institutions. For us, our FNAs are often done by pediatric interventional radiology. Sometimes that's done at the adult hospital, maybe by you, the thyroid surgeon, maybe by your endocrinologist. So kind of having, I think, experience is really important with kids and making them feel comfortable. Also, what are your options for sedation or anesthesia? Is it just local anesthesia? Is it general anesthesia? Is it somewhere in the middle where you kind of have anxiolysis and, kind of how much of a menu do you have in determining that? And other speakers are going to go into the details of how we could use these genomic classifiers. But are those available at your institution? Do you have a protocol for running the cytology if you have enough material and kind of getting further studies when that's needed? I love pediatric thyroid, but it is a team sport. Um, Teams that are often involved in the initial evaluation are yourselves, the pediatric otolaryngologists, or other thyroid surgeons, us as your endocrinologists, radiology and interventional radiology, pathology, so communicating with your colleagues and kind of talking to the people who have thyroid pathology experience is a really important resource. And if you are so lucky to have a nurse coordinator or a social worker, those who do understand that they are really kind of the hub of that wheel and they really provide great patient care. So, having a whole team is really important. Other teams, I think, if you do have a diagnosis of a thyroid malignancy, nuclear medicine, oncology, and having a genetic counselor are just really important. So kind of developing that network, whether it's formal or informal, I think is really important. So just a few more thoughts about building a pediatric thyroid program. Um, find your teammates, find your pediatric thyroid uh, um, affinity team members and organize. Can you schedule coordinated visits? Could you actually see them at the same time or kind of back to back? I think a lot of care has been streamlined and improved through clinical care pathways, both for inpatient and outpatient care. So that can really kind of be helpful. And then, at least in our experience, and I think in our the other speakers' experience, I would say that using the adult thyroid expertise at your institution is invaluable. There's a great infrastructure there. There's great synergy. And developing a tumor board, either that's just pediatric or kind of combined. Those can be, I think, really helpful for developing expertise and kind of sharing knowledge. Great. So care for children with thyroid nodules and cancer involves various subspecialties, and establishing these partnerships are really key both for you and for providing great care for your patients. And that is it. Please email me with any questions. Let me unshare.
Thank you, Hillary, for kicking off our webinar. Um, Next up, we have Dr. Kara Meister, who's a pediatric otolaryngologist and co-director of the Thyroid Center at Stanford Children's. And she'll be talking to us about some exciting updates on thyroid nodule classification.
Sure. So thank you all for being here. Thank you, Grace, for organizing, and Liz for your expertise in helping us get the wheels turning here. So I'm Kara Meister. I'm an assistant professor at Stanford Medicine Children's Health, and I have the honor of privilege of working closely with Hillary and also now with Grace in caring for this population. And we're going to really concentrate for the next few minutes on how we think about classifying nodules, right? So it's really important as we move into caring for kids specifically that we understand the background of different classification systems and how to apply those to this very specific population. So, how might we classify nodules? So, we can classify them by ultrasound. There are several different classification schema that revolve around ultrasound. The most well-known in the US is the American College of Radiology Thyroid Imaging Reporting and Data System, also known as TIRADS, which came about in 2017. The American Thyroid Association, as well as the British Thyroid Association, also have ultrasound-based classification. Um, the second way that that nodules are commonly classified is by cytopathology. And what is familiar probably to most of you all is the most common classification system therein is the Bethesda system for reporting thyroid cytopathology. And then we have some next gen classifiers. And this image came from one of our medical students who had a field day with generating us some AI thyroid next generation imaging. So I thought I would include it here. But we're seeing a lot of data come out about elastography as a way to classify nodules, different AI classifiers, and even other imaging tools such as Raman or mass spectroscopy. Where we're going to focus tonight is in the two most common, so TIRADS and Bethesda. Okay, so TIRADS. As we stated earlier, so this came about in 2017. For those of you that don't know about TIRADS, it is a point-based approach. It is a way to communicate, right? So it is intended to be a communication tool, okay? Over the years, it has also developed into an algorithm to give specific management recommendations. And the primary goal when TIRADS was conceptualized, validated, and has been, now looked at in the literature is really to two things: to reduce unnecessary biopsies and to improve the diagnostic accuracy for those patients that do go on to have a biopsy, and create this reproducible framework for assessing a malignancy risk of a thyroid nodule. The subcategories, there's composition, echogenicity, shape, margin, and the echogenic foci. And then each of those gets a point. You come to a total score, and then based on that total score and then some size criteria, a recommendation is given. Okay, so we're going to walk through a case, and I'll use that case to hopefully illustrate some salient points about using this classification system specifically in children. So this is a 12-year-old girl. She was seen by her local endocrinologist for increased height, actually. She was found during her initial evaluation to have abnormal thyroid function test. She was anti-TPO and anti-TG positive, family history of scleroderma. The endocrinologist performed an ultrasound of the thyroid for asymmetric gland on palpation. That was in June of 2023. And we don't have these images, but the report from that ultrasound commented on a sub-centimeter nodule, the right upper pole, and then at the isthmus. Both of them were classified as TIRADS 2. And then specific recommendations were that this is not worrisome and they do not meet criteria for follow-up or biopsy. Okay. And so the family continued to see this endocrinologist to follow up for thyroid function test. And not surprisingly, they got another ultrasound 9 months later. Even though the initial ultrasound said that they didn't need any follow-up, this very astute endocrinologist just decided to do such. Okay, and now we have 9 months later this image. So right isthmus nodule, not really changed in size, if you look at things overall. And they scored this again as a TIRADS 2 and gave a recommendation of no follow-up or FNA. Okay, so then the family came to see us at Packard because they were high information seeking and wanted a second opinion for these abnormal thyroid function tests and this, kind of questionable nodule that they saw. And when they came to our institution, It's our institutional protocol. We repeat the ultrasound. We get a new baseline when we do an intake of a new thyroid nodule patient. And you'll notice that in this report, we have similar size isthmus nodule, but slightly different descriptors. Okay, 2 months later, slightly different descriptors. Now, what's different in this report is you don't see a TIRAD score, right? And so our institution does not typically include that in our protocolized thyroid ultrasound for the pediatric population. And we'll talk a little bit about why that is. So there's no TIRAD score here, but we're going to use these same criteria that it was described as, and we'll create our own. Okay. So when we look at all of these different subcategories and we assign points, if we go back here, so our composition is mixed, solid, and cystic. All right, so that's going to take us down to 1 point, okay? Now we have hypoechoic. That gets us 2 points. We're at 3 points total, right? Um, Wider than tall, I will tell you, is 0 points. Margin has now changed to be described as lobulated or irregular. And so now we're at 2 points, okay? And echogenic foci, none, which is 0 points. So if we add that up, we are between 4 to 6 points, which takes us to a TIRADS 4, moderately suspicious. And then when we look at our algorithm for this, we would FNA if greater than 1.5 centimeters or follow if 1 centimeter. Okay, so of course, now if we go back, remember when this patient came to us, the size of their nodule was exactly 1.5 by 0.8 by 1.2. And so we decided to biopsy, actually. I will tell you that Dr. Seeley and I see patients together. We look at every ultrasound together and with the family. And it was the border, really, more than any of this that pushed us over the edge. Okay. So in the report of this ultrasound, they never give a TIRADS, but they do actually give a management recommendation. They say, consider tissue sampling versus interval follow-up. So this is the discussion we have with the family, and we proceed with tissue sampling. So what I didn't tell you about this, but you may have picked up from a few of the nuances of the ultrasound, is this was not the only nodule, okay? So this is the one that I'm presenting, but in fact, she had multiple nodules throughout her gland. And then the question comes, okay, we're gonna biopsy one of these. Which do we biopsy? Do we biopsy the right superior pole, the left superior pole, the right mid pole, that isthmus nodule? And as we think about our team dynamics, this is where really working closely with your collaborators to have that open dialogue helps. So we like to be very discreet when we're speaking with our interventional radiologist, and we tell them exactly which ones we want to biopsy. It's kind of our protocol. We get we go through the gland. We really spend a lot of time communicating this, and just the same amount with the lymph nodes as well. Okay, so of course we biopsy this isthmus nodule. She goes on to have a total thyroidectomy, which ends up being a T1B classical type papillary with an intrec rearrangement. So, okay, so I'm going to pose a little bit of a provocative question, and that's, are there any thyroid cancers in kids that are not clinically important? Okay, and the reason that may sound a little jarring is because that's essentially what we're doing when we use the TIRADS schema for kids. So if we go back and we think, why do we have TIRADS? Well, it was developed for low-risk patients under the premise that not all thyroid cancers in adults are important. And remember, their goals were twofold: to decrease the number of nodules needing follow-up and to increase the true positive biopsy rates. So many of our patients are not low risk. They've had previous radiation, they have a genetic predisposition syndrome, they are a child, right? We know that the prevalence of cancer and thyroid nodules in the pediatric population is higher at baseline than it is in adults. So while lower sensitivity in a 70-year-old adult with a T1, PTC might be okay, lower sensitivity in children is probably not okay. And there have been two recent studies that really try to drill down this concept. The first one is from our colleagues from Vanderbilt, just came out, and it's looking at applying TIRADS to pediatric nodules. And when they look at their experience, they're looking at their risk category over here, so 1 through 5, okay? And then of those, how many kids ended up having cancer? And you can see that not insignificant number in our TIRADS 2, 3, and 4 had underlying malignancy, right? And so the recommendation from this paper is that the classification is okay, but we need to maybe downshift the management so that we are biopsying more nodules. Similarly, in 2003, the Hess group looked at all of the published data as well as their cohort of patients for a total group based around 1,500 cases. And they found almost exactly the same thing as reported from the Vanderbilt group. And that was even in TIRADS 1, 2, and 3, there's a significant risk of malignancy. And so these pieces of literature really tell us that the classification, if we're using it as a communication tool, that may be okay, but really the management can be off. And as a pediatric otolaryngologist or a person caring for kids, you need to understand that the ultrasound report you get may not have this caveat to it, okay? Okay, so we're going to switch gears and we're going to talk a little bit about Bethesda. So the Bethesda system really is in a similar vein, a standardized system that's used to classify FNA results, to guide treatment decisions, and in recent years, it's also been applied to the pediatric population. It utilizes 6 categories, but if we look at that risk of malignancy in our pediatric patients, again, that we can find not insignificant ROM or risk of malignancy, even in our Bethesda 1, 2, and 3 classifications, okay? And I'll point out that in this group of around 6,000 cases classified as benign, Bethesda 2, about 7% of them actually had risk of malignancy there. So similar to the TIRADS thought, the Bethesda category may imply higher risk of malignancy in children than in adults, okay? A few comments here about the challenges and some of the specifics. So when we combine our sonographic findings and our Bethesda results, that can be very helpful clinically, right? So sometimes Dr. Seeley and I will see a patient where it just doesn't look good on ultrasound. And even if we have a fairly reassuring FNA result, we'll still talk to the family about, at a minimum, planned surveillance, even up to the point of lobectomy. So those nodules that you should be especially suspicious of are the large nodules. There was a review of 237 nodules, all biopsied as benign, okay, Bethesda 2, biopsy benign, that were either followed by ultrasound or eventually resected. And they eventually did find thyroid cancer in 6 of those nodules, okay? So I put in a plug to just keep following these kids. Just because you have one benign FNA, if your spidey sense is up, it's totally reasonable to keep following them. The one to be very wary of is greater than 4 centimeters. So in this cohort, now granted, now we're getting to pretty small numbers, those that had a size greater than 4 centimeters had a 15% chance of malignancy despite their benign FNA. And those nodules that grew during follow-up, and then flexion points seemed to be around 6%, also had a higher rate of malignancy. The other thing that we see clinically and has recently been published is that the sensitivity for detecting papillary thyroid cancer in those Bethesda 5 and 6 FNAs may be lower in children with autoimmune thyroiditis. And many of our children do have an underlying background of autoimmune thyroiditis. Okay. So the big takeaways here, TIRADS may be useful as a classification system, but be wary of those adult-based management recommendations. Think about downshifting. So if you have a TIRADS four that may not meet that 1.5 centimeter criteria for biopsy, go ahead. You can think about downshifting and proceeding with a biopsy in those cases and so forth. Secondly, the Bethesda categories imply a higher risk of malignancy for pediatric patients compared to adults, and be especially wary of those greater than 4 centimeter nodules and those patients with autoimmune thyroiditis. Okay. And that's what I have. So I'll stop share.
Great, thank you. Next, we have Dr. Amy Demakier from Texas Children's Hospital, where she is the surgical director of the pediatric thyroid program as a pediatric otolaryngologist. We'll be talking about the genetics of pediatric thyroid disease.
All right, thank you, Grace. Am I unmuted? Yeah. You can hear me okay? Right.
Yes, we can hear you.
Thanks, sorry, I can't see on my screen. All right, I'm super happy to be here. I'm Amy Demachki. I'm the surgical director of our thyroid program here at Texas Children's, and I'm happy to see some friends joining us here on the webinar. I love pediatric thyroid cancer. I love kind of the uncertainty of it, as Kara is alluding to, is how much do we not know? And that's the reason that we're sitting on recommendations from the ATA that are almost 10 years old, is because we've literally been debating how to change these and how to use the information that we have going forward to make better management decisions. We want to make better decisions based on imaging. We want to make better decisions based on Bethesda category. And now we want to make better decisions based on genetics. And so this is a lot of the conversation moving forward in pediatric differentiated thyroid. And I've condensed what I get really excited about for 2 hours into like 12 minutes. So we're just gonna go through some background in the role of molecular genetics, and then how to think about those genetics in decision-making, both surgical decision-making and medical decision-making, which I think is part of the excitement here. So inherently, all the information we have basically in peds, except for some of the larger studies highlighted here, are in adults. But adult pediatric cancer is not pediatric cancer. And it's amazing how it's so dramatically different. It comes down to the genes, right? These are RET PTC mutations in the pathway, and they're not in the same pathway as our adult BRAF mutations. And so inherently, these cancers are different. And we know this. We know these cancers, they're presenting early, they're multifocal, they have lymphadenopathy, they're more aggressive. But survival, thankfully, is still very good. But how do we use this information about the genetics going forward? So looking at studies, and this has been repeated time and again, doing molecular genetics on as in the Stanford patient, on our specimens shows that adult patients are typically BRAF mutations. These are point mutations, missense. That's in 62%. And then in our pediatric patients, we're looking at these fusions. These are fusions, these are RET PTC, these are NTRK, these are BRAF V600E. So these are different mutations. And then we get our predisposition dicer P10, which my friend and colleague Lauren will talk about a little bit in a little bit. And so this was repeated again. We're looking at the oncogene fusions. And so looking at 52 patients of pediatric PTC, of the ones sampled, 98% had a targetable genomic driver, right? And so these are looking at the fusions, and it is definitely stratified by age. So looking at the age in the lower left, this is F. You can see that the fusions are more present in the lower and the under 10, and then decreasing into our teens, where you start getting into those substitutions and point or unknown mutations. But that also not only drives the age of presentation, but it also drives the aggressiveness of the tumor, right? So when looking at lymph node metastasis, distant metastasis, and angioinvasion, or signs of more aggressive ATA, we're getting into those ATA intermediate risk and high risk patients. We're looking again at those fusions. And so understanding these fusion transcripts and how they work. So looking again, this is in stratification. In the center, you're going to see stratification based on the NTRK, the REC, the ALK, that BRAF V600E that we talked about, and then the dicer. And you can see that drastically different, that red line being those under 10s. So that's way more prevalent in our under 10 kiddos than in our dicer patients or in our older patients with that BRAF. So we have this information and we're collecting this, but what does this mean? And what do we do with this as surgeons? And how do we use this with the imaging and with the Bethesda category to help decide how to best guide our patients in decision making and manage these pediatric thyroid cancers? Right? So we have a targetable assessment. We know that these fusions is just another study looking at the BRAF V600E, and then looking at this ATA risk stratification, right? And so this is where we start getting into management guidelines in the upper right. And we see that most of the high risk patients are actually fusions, okay? The intermediate risks are the BRAF, and then those low risk, some of those DICER-P10 or some of those other mutations. And so this is out of the Chop Bowers group, and this was just published this July. We're trying to identify what are the low-risk invasive mutations and what are the high-risk invasive mutations, and how does this change your decision-making for surgery? So one of my favorite debates is our prophylactic central neck dissection. I think most people know I don't do a prophylactic central neck dissection, but some of my partners at Chicago at Chop do prophylactic central necks, and so I want to know why and who would benefit from the prophylactic central neck. And the CHOP group says, like, well, if you know the cytology, the driving, the genetic driver in the cytology, and you know that it's RAS, P10, and DICER, you know that that is a um, low risk, low invasive driver, and you would not do a prophylactic central neck. On the other hand, if you have one of the NTREX or the RET or the PTC fusions, then you're getting a more high risk invasive. And so using this information with the understanding that not all institutions get cytology with molecular genetics, and it's more common to get it after in high risk patients. So then we have to look back at the imaging on these patients. And like Dr. Meister alluded to, is how do you identify using other imaging, Bethesda, other techniques to identify? And so they touch on this in this group where you talk about that smooth margin versus the lobulated margin and trying to use that imaging to guide decision making. So this is our 2015 guidelines, right? So this is going back, this is the Francis et al., the ATA guidelines. And we just use that stratification based on low, intermediate, and high. And then we do stimulated TG scans and we go down the RII pathway, right? So you've done surgery, you know the risk category, and now you're deciding for adjuvant therapy. But I have to say, we're really rolling back on the RII. I have given so much less RII in my last 2 years of practice than when I first started. And why is that? I'm seeing more advanced thyroid cancer, I'm seeing more thyroid patients, and why is it that I'm using less RII? Right? And this goes back to the genomic drivers, right? We know that RAI carries risks, and we know that an excellent response to RAI is uncommon. We rarely get that perfect response where you drop the TG super low. And it obviously carries risk. So then you have to use those genetic drivers to better understand who's going to do well. What are those tumors that would do well with RAI? And that's where we get into targeted therapies, right? We know that there's a targetable fusion driver, and now we have a targeted kinase inhibitor, right? So these have a much better side effect profile because they're not general VEGF receptor. And so the patients tolerate them very well. They're oral, they're tablets, which is difficult for some of our younger patients to take. But they have been shown to decrease and encourage tumor regression and to improve radioactive iodine uptake, which I think is super interesting. So this is a list of just the FDA approved targeted therapies. The most common ones we're going to come across are selpercatinib and pralsetinib, which are good for our RET alterations, and the larotrectinib, which is our NTRK, are kind of because of more commonly used medications. This was a paper that includes some of the group here, talking about a shift in paradigm. It's like, are we talking about using this not only in adjuvant therapy, but are we talking about potentially in neoadjuvant, right? Are we going to use it for our high-risk patients where there might be injury to the aerodigestive tract, or you're looking at like circumferential carotid disease, or really extensive mediastinal or pulmonary lymphadenopathy? And over the last couple of years, there are several reports just coming out of multiple institutions of using these targets in a neoadjuvant setting and seeing really excellent responses and getting these patients timed up for surgery. So here's the use of selpercatinib and then some of the NTRK medications. So then the The other part in the adjuvant setting is improving radioactive iodine sensitivity. And I've actually experienced this multiple times in my own patients where I've used it in an adjuvant setting. And so in I-131 refractory lung disease, some patients were given selpercatinib and it actually differentiates the tumor, improves the iodine symporter so that you actually get improved iodine uptake sensitivity before administering the final 131. And so you can actually restore iodine sensitivity with these targeted medications. So super interesting. I don't think I have time for that, but I can hold on to a case later if we have time in a bit. But I want to give my friend Lauren here a good time.
Great, thank you. And our final speaker is Lauren. I'm going to butcher your last name. I apologize again. Lauren Desrosier Batu, who's a genetic counselor in the section of hematology and oncology at Texas Children's Hospital. And we'll be presenting an even deeper dive into genetic evaluation of pediatric thyroid nodules.
Hi, thank you. So again, my name is Lauren Batu. I work with Dr. Jamashki at Texas Children's Hospital, and I'm a certified genetic counselor for our Texas Children's Cancer Center, and I'm the genetics lead for our thyroid tumor program. And I'm really excited for the opportunity to talk with all of you this evening. And I'm really planning to give you a very high level brief overview of hereditary predisposition to thyroid nodules and cancer, talk about some existing referral guidelines for this population, and then talk about some genetic testing considerations. And I do want to highlight that the conversation that I'm planning to talk through with y'all today is very different than what Dr. Damashki was talking about in terms of somatic testing. I will give a highlight of somatic versus germline just to give you a little bit more context, but those are two very different types of genetic testing with different objectives. So the multiple endocrine neoplasia or MEN syndromes are probably the most familiar to this group, particularly MEN2. The thyroid cancer risk in MEN2 is specifically medullary thyroid cancer, and the age of onset can be quite young, particularly in patients that have MEN type 2B. And the surveillance and management guidelines are really dependent on the specific mutation, which we call genotype-phenotype correlation. And then we then categorize patients based on their mutation into the highest, high, and moderate risk groups from the ATA. And then depending on the risk group by the mutation, then we recommend different approaches for prophylactic thyroidectomy in those patients, ideally. Some conditions you might be a little bit less familiar with that predispose to thyroid nodules and cancers are listed on this slide. These are directly from the ATA guidelines. FAP or familial adenomatous polyposis is really associated with cribriform marular variant of papillary thyroid cancer. And really, in my experience, thyroid cancer is often not the presenting features in families with FAP. The penetrance of colorectal cancer is much higher in these families than thyroid cancer. So oftentimes we're diagnosing families based on colon polyps or cancer before identifying thyroid cancer, but it can present in childhood. So it's possible to identify someone from thyroid cancer first. The next condition is Carney complex, which is associated with thyroid and several other endocrine tumors. This often presents with some skin pigmentation differences, and I'll say we don't typically test for this often in our clinic. The next two I want to talk about are DICER1 and PTEN, and these are the ones that I most often talk about in our thyroid tumor program. DICER1 is one of the more newly described conditions, especially in this list. And the penetrance of the condition can be a little bit challenging in terms of identifying these individuals because the thyroid disease may be the presenting symptom in the family. And then in terms of PTEN, it can be highly variable, and patients can present with personal or family history of cancer. They can have other medical problems like autism, learning differences, skin findings, etc. And even without a suggestive family history, many patients will actually have macrocephaly, so increased OFC, and obtaining a head circumference could be helpful for risk assessment for this particular condition. And then unlike the dominant conditions that I've talked about, I also included Werner syndrome, which is a rare recessive condition associated with premature aging. And we don't typically see that in our patient population. And like I mentioned, in my experience, the most common conditions we typically are considering and identifying from our thyroid tumor program are Dicer 1 and PTEN. So with that being said, I've listed some of the red flags for hereditary cancer syndromes, and these are for hereditary cancer syndromes in general, not specific to thyroid cancer. Specifically with age of onset, we actually previously used to see all of our pediatric patients with differentiated thyroid cancers. Anecdotally, our yields have been kind of low from a germline perspective, so we may need to refine some of these age cutoffs in our population. And I think this is a really great area of research moving forward. In terms of patients with multiple primaries, the one thing I want to point out is that thyroid cancer is a common secondary malignancy in patients that have had radiation. And so if the thyroid cancer is a second primary, it's important to consider whether the patient has had radiation exposure, because that would actually decrease your suspicion for a germline predisposition condition. And then in terms of family history of the same or related tumors, when I say related tumors, I actually mean ones that can be linked by the gene. So for example, pleuropulmonary blastoma, which is a lung tumor in young children, can be linked to thyroid cancer through the Dicer1 gene, and then colon polyps and cancer can be linked to thyroid cancer with PTEN. And then again, some of the unique clinical characteristics by themselves are sufficient to actually warrant genetics referrals, such as medullary thyroid cancer. So I did want to highlight that the red flags may be helpful for risk assessment, but the referral guidelines are relatively limited in this population still. And I think that partially has to do with the fact that these guidelines haven't been updated since 2015. But these are the two recommendations from the ATA guidelines that specifically comment on genetic evaluation for thyroid nodules and differentiated thyroid cancer. I did not include the guidelines for medullary because all patients with medullary thyroid cancer should be seen by genetics for evaluation. And it's important to note that the differentiated thyroid cancer guidelines just list that patients at increased risk for germline disease or familial differentiated thyroid cancer should be seen, but they don't provide a lot of context for what that looks like. Although they are a little bit more concrete when it comes to follicular thyroid in recommendation 32C. So I also wanted to highlight this tool for pediatric cancer in general, which is called MIPOG, or the McGill Interactive Pediatric Oncogenetic Guidelines. They have two different questionnaires in their online tool that are relevant to patients with thyroid nodules and or non-medullary thyroid cancer. Like I said, it's freely available. It can be accessed online or via a mobile app. I will say it defaults to French since it's from Canada, but the language can be changed to English. And I just combined all of the questions that are asked in that in those modules into this one slide for quick reference, but it walks you through question by question. And I'm sorry, I think I might have missed a comment. No? Okay. Moving on, I want to keep an eye on time. So I did want to highlight the difference between somatic and germline testing for patients in general. So somatic testing is really designed for the treatment of the current cancer. These tests can be widely variable. They can test for single variants like BRAF V600E. They can just test for the RET fusions, or they could be much larger panels that include analysis of point mutations and fusions in hundreds of genes. It's often used to make treatment decisions. An example of this kind of testing in the thyroid space is ThyroSeq. Germline testing, in contrast, is really intended to help identify a cause for the patient's cancer. Sometimes that's helpful for families. And also to provide surveillance guidelines for additional cancer risk. Most of these types of panels are DNA only, although you can include RNA sequencing to help clarify some variants of uncertain significance. And typically these panels are much smaller than the somatic tests. They don't include fusions because those are typically not hereditary. They're not often passed down in families. And often if we find a positive result, it will actually include recommendations for cascade testing for family members. And I just wanted to leave you with the fact that there are several different labs that offer testing for hereditary cancer, hereditary thyroid cancer. The panels differ in gene content by lab, but they typically use a next generation sequencing approach, again, for point mutations or small insertions and deletions. The panels that I was able to find so far all include the genes that we talked about, but they also may include additional genes. One of those that I haven't mentioned is called TP53. It's a tumor suppressor that is associated with Li-Fraumeni syndrome. That particular gene is implicated in multiple different cancers. Thyroid cancer specifically isn't one of the core cancers in Li-Fraumeni syndrome, but because it's an important tumor suppressor, it is added on pretty much any hereditary cancer panel you could order. And then there's also some emerging evidence for other genes associated with microRNA processing, as well as some of the long telomere genes like POP1, but those have not been added to panels. And to my knowledge, there haven't been any pediatric cases reported in the long telomere genes yet. And then this is just another tool that I often use. This is called Concert Genetics. It allows you to compare different genetic tests. So this is just a screenshot. You can choose whichever tests you'd like to compare, and it gives you a whole bunch of different information. It, I think, was primarily designed for genetic testing, but it actually has all kinds of different laboratory tests. I saw TSH, et cetera, when I was preparing for this talk. So definitely a tool to consider using. And with that, I thank you for the opportunity to talk with everyone, and I'm happy to take any questions.
Great. Thank you, Lauren. And I'd like to thank all of the speakers for an amazing series of talks about pediatric thyroid nodules. And I just want to remind our participants that you may unmute and ask your questions, or feel free to use the chat box. I have one question here already, so I'll start with that for our audience. I'll just repeat it. Given TIRADS and cytopath underestimating the risk of malignancy in pediatrics, do you routinely order genetic testing on FNA samples, even if reported as benign, to test for fusion genes, etc.?
So I can tell you
That was
a
from
little bit.
Diane Chen.
Sure. So this is Kara Meister. I can tell you our hope and then our reality. So we would love to do this. It's a little bit logistically challenging. So when we first started our program 6, 7 years ago now, we weren't routinely kind of banking an extra FNA in case the cytopath came back as a Bethesda 3 or 4 to be able to send it back. And then we went through, a year or two of then having to take the patient for a second FNA. And finally, we worked out such that we now kind of keep an extra FNA on reserve to be able to send this. And so we still, if we're going to send it out for ThyroSeq, it is still only for those Bethesda 3 and 4. And so you might still would miss something that did not qualify for those send out tests. That being said, we do have pretty good experience with our in-house markers, which include both STAMP, which is the Stanford Actionable Tumor Panel, as well as STAMP Fusion, which focuses on fusion. We can occasionally get them to run that on an FNA if we have, like Dr. Damashki was saying, a very aggressive tumor where we think it would change that upfront management. So if we're thinking that we would offer neoadjuvant targeted therapy, we have at times done that, but it's not part of our routine algorithm yet. Say, Hillary, is that fair?
Yeah, totally agree. Interested to hear what you do in Texas.
Thanks. Yeah, we're pretty similar as routinely, and Dr. Chen, I know, just introducing her, she asked the question, talented head and neck and pediatric otolaryngologist in Indiana. So thanks for the question. So we do not, I routinely send somatic testing on intermediate or high risk. So if I'm considering using a neoadjuvant setting, then I routinely send for high risk. But this is really interesting because, Lauren, just in tumor board this week, we have, it was a Dicer patient, right? And we're talking about management, multiple nodules, biopsy benign. There's like 6 nodules. We know it's a Dicer 1, risk of malignancy is like 38, 40%. what do you do with that patient who's 17 years old and going to college next year? Right. So I'm totally with you. I don't think it was part of our discussion. It's part of us kind of learning and looking back at our own institutional data and say, if we do thyroidectomies on these patients, the risk of malignancy is still really under 38%. Right. So are we missing, kind of goes back to, are we missing clinically relevant disease with a negative biopsy? I don't think so. But having as resources, depending on institutional resources, I think it's a very interesting conversation. But I do routinely send high risk because I've used neoadjuvant several times over the last couple of years. I think it does have its advantages.
Um,
Thanks for the question and the plug.
And along the same vein, we offer every patient who's had thyroid cancer, no matter what their somatic testing comes out, we offer them referral to our genetic counselor because we have on occasion found germline differences that were missed in the somatic testing. I think extrapolating from other pediatric cancers, that rate's between 8 to 12%, so not infrequent. And we found, multiple different germline mutations that we wouldn't have had on our radar. So that's just part of our algorithm. It's part of our philosophy, and our institution has been supportive of that. So we're very appreciative.
Thank you. I don't want to take anyone else's opportunity to ask more questions, but I do have another question, if that's okay. Does anyone have any experience with radio frequency ablation for benign nodules? Is this like a new technology that's been used in adults? But in our ped IR group is very hungry for cases. I'm very hesitant because there's not any evidence in peds, obviously. And there's, if you are too close to the recurrent laryngeal nerve, you can ding it with this technology, even if it's benign. So I was just wondering if you guys have any experience with that.
We have a protocol open and an IRB for radiofrequency ablation of single cystic lesions in the anterior gland. The only caveat being is that they have to be symptomatic. And I've yet to find a patient to recruit. So we have this open IRB for a cystic lesion. If anybody has one that they want to do, I totally agree. My IR guy is probably in cahoots with your IR guy because he comes in every week to ask if we have one. And
Oh my gosh, seriously, every time I refer them for a biopsy, they're like, can we ablate? And I'm like,
no. Is the patient symptomatic? And vastly no, right? Is that most of these patients, we have had some cosmetic ones, but then we'll do aspiration, the cyst partially resolves, and then so we haven't had one yet. We can text me some if you get one, and we'll get in line.
yeah, we can collaborate because I sent one for a growing nodule, but I already did a lobectomy on this patient, and this patient just somehow likes to grow follicular adenomas. So I did a lobectomy, and then he has like this like small 1 centimeter contralateral, and I hate to render him hypothyroid. So I was like, okay, it's slightly growing in the past 6 months. That's my only one that I have said, yes, try radiofrequency ablation. So maybe consider it like growing cystic lesions because if you aspirate, it always comes back.
Yeah, they're still not symptomatic. So I haven't found one that's part of the part of our radiology build IRB. But I'm there.
I'll chime in that we've done a handful. I think maybe 4 patients for our thyroid nodules, and then Grace, you know this data better than me, a handful actually for lingual thyroid that was not totally responsive to suppression. Our first couple of patients went great. I'll say the most recent one I did, it has bilateral, and one of them is right at that 4 centimeter margin, and I'm a little bit worried. So all of them have to have 2 benign biopsies. So they have to have 2 separate Bethesda 2 whatever we're RFAing, and I've been doing them in the OR with a NIM tube in because I'm scared about the RLN. And the most recent one had minimal response, and so I told her that if the next round, she wants to do 2 rounds, so I told her if the next round doesn't work, then it's lobectomy time because my spidey senses there's something's wrong with that nodule. So, yeah. Grace, do you want to add anything about RFA or Hillary?
Just for the audience, the thyroid nodule patients that you RFA'd, did they have symptoms?
They had symptoms, but more cosmetic. Yeah. The symptoms are hard because sometimes the patient, and I think we see this with lobectomy as well, they don't realize that they had a symptom until it's gone, right? They're like, oh, it actually was bothering me. But then you wonder, like, does that matter? So do they need an operation for that, right? So, yeah.
We have another question from one of the participants, Jeremy Prager. Teenagers with 1.5 centimeter Bethesda 3M with NRAS mutation on thyroid, Hemi versus total. Family has strong opinions and trying to guide them in this gray area with adult data and little but growing peds data.
I guess I'll chime in. I routinely do lobes for Bethesda 3s. Our looking at our own institution, the malignancy rate was just around 20%. So I can't be, so I do, especially with I don't do, thanks for the question, Jeremy, by the way. I don't do genetics on those. So that's interesting. And I'm bringing in kind of the CHOP data on those low invasive risk, because I know that, they have some different opinions about that, but given the Bethesda category, lobectomy. Yeah, I was wondering that.
Yeah, Jeremy, nice to see you virtually. I'll chime in. I actually was just texting Hillary in the chat that we have this exact patient that we took care of not too long ago. Same thing, Bethesda 3, T1B size nodule got sent out and was NRAS positive. And, I counsel the family that, this particular patient was 15, so post-puberty female, which to me makes a difference in some of my decision making. No other nodes, nothing else looked suspicious. The other, contralateral side was totally benign. And we offered a lobe and it came back as follicular lesion of undetermined malignant potential. So still in that black box, but now your risk of malignancies down between 1 to 3%, right? And so we're going to continue to monitor her if we're not taking her for total thyroidectomy. So yeah.
And normal thyroid function. I forgot yours
Normal
is,
thyroid function.
yeah,
Yes.
yeah.
Yeah, just one thing to add from a modest non-surgeon opinion, right? So these are the patients who you may reoperate on, right? So if they don't have a history of radiation, right, to the head and neck, then I think a lot of these things, like if you know that if they need to come back, they're coming back to you, maybe that gives you a little bit of a longer leash to think about lobectomy versus total thyroidectomy. So just from an observer's point of view.
All right. Any last minute questions from the audience or the speakers? If not, thank you everyone for joining. We are finishing right on time. So thank you everyone for a really engaging conversation on pediatric thyroid nodules. And please let us know if you need anyone's contact information. But the webinar will be posted online at some point, I have been told. But thank you again for joining on a late Thursday evening. Goodbye, everyone.